Sponsored by Dennis J. Courtney, M.D., Director of the Courtney Medical Group, located at 3075 Washington Road in McMurray, Pennsylvania. For more information or to make an appointment, call 724-942-3002. That's 724-942-3002 for Dennis J. Courtney, M.D.
Good morning, everybody. Good morning, everybody, and welcome to AM Impact on Your Health. AM Impact on Your Health, where every day our goal is to have you learn at least one thing to help you live better and longer. AM Impact on Your Health, of course, heard every Monday, Wednesday, and Friday from 8 to 9 o'clock. I'm Dr. Dennis Courtney, and I'm with you each and every Monday, Wednesday, and Friday from 8 to 9. AM Impact on Your Health, where each day you'll find current medical news, knowledgeable guests, fascinating health topics, and of course where we do encourage you to call in to join in. Today, well, the word old friend, I use it a lot. This is an old friend. It's been about, I'm saying at least 2 years since we had him back here. We talk about him all the time because, well, we respect him so much. His book, Reverse Heart Disease Now, in collaboration with Dr. Steven Sinatra, another well-known cardiologist, has been sitting on my desk for quite some time. And many of you have purchased it on my recommendation because, really, New Age cardiology has been practiced for quite a while. It just hasn't come to your Pittsburgh venue just yet. So you have to be prepared with your cardiologist as well as your family doctor. And here, you won't have to be prepared. We've been doing this kind of New Age cardiology for quite some time. It's been an influence on me. Dr. James Roberts, our guest today, and he's always got new things he's into. I always have a list of things, and I do have one today, about some things I want to just tick through because, well, in most cases, he was the first one to bring them to us. So our guest today, Dr. James Roberts, right after that first break with, well, is it Reverse Heart Disease Now, New Age Cardiology, or just what's new in the life of Dr. James Roberts? We'll be back with him right after that first break. If in the course of our discussion with him today, you want to call in to ask a question or make a comment, that number, as always, will be 412-825-6262. That's 412-825-6262. Now, looking at the calendar, well, let's just go back one bit here. On Monday, I hope you did come aboard and were able to listen to our show that we did with James Navarro. Of course, he's the father of now deceased Thomas Navarro, a young guy that we first brought to you. That entire family saga was brought to you live and in person way back, really in the year 2000 and 2001. But here it is. It's about 10 years later, and the documentary being released on Thomas Navarro's life is going to dredge up a lot of ill will that was put to rest. At least, I think on the part of the government, the FDA, it organized medicine. They would have hoped that it was put to bed, but I think it's going to get resurrected again, and I think only good can come of it. I think we learned, if you hadn't met the Navarro family, in particular Jim Navarro, before, you did meet a father who anguished over how his son was to be treated. We now reveal to you, if you didn't know before, that you as a parent have absolutely nothing to say when it comes to how your child will be treated. What you should have learned from our show on Monday, and certainly had learned when we initially brought you this family's plight back at the turn of 2000, 2001, was that as an adult, with respect to your own treatment, yes, you are allowed to make all decisions, and nobody can coerce you into doing anything against your will. Probably because of that strong sense of right and indignity to think it would be any other way, you are tranquilized by that to think, well, it must be the same for every aspect of my life and my family. As you would have found out on our Monday show, and certainly would have known had you followed this earlier on when we brought the family issues to you with Thomas Navarro in mind, you have no such right when it comes to your children. And it will not be you who determines the treatment that your child will receive. It will be government policy, government protocol, things outside of your control. And that was the entire battle of the Thomas Navarro saga that led us to literally follow that family. Sometimes I spoke to them, as I mentioned, in a phone booth with a handkerchief muffling the mouthpiece of the phone. They just couldn't reveal where they were. They were worried about their phones being tapped, all that crazy stuff. Anyway, what they're hoping, with the release of a documentary, 87-minute documentary, going to be released on the Thomas Navarro issue in its entirety. It has a catchy name, folks. Cut, Poison, Burn. I don't think I have to fill in any gaps as to what that's all about. Anyway, it's going to be a release done at the Mill Valley Film Festival. Now, I don't know much about film festivals. They claim that this is one of the top 10 in the world, but October 7th to 17th, there's going to be a release of this 87-minute documentary, and it will dredge up that whole ugly but very necessary issue of who's in charge when it comes to determining what treatments not only you'll get, because you're already given that right as an adult, but your children, I don't think you knew. Don't think you do know that you are not going to be able to make those decisions. They're made for you. This, of course, is leading up to the reintroduction of what has been called then and now will be called once again the Thomas Navarro Patients' Rights Act, which after this is launched, I think you're going to be seeing and hearing a lot about it. I got an email after the show was over with from Jim, who listened to it on the link. By the way, those who missed the show can go to my website at djcmd.com and click on archives, and then you'll see the show we did on the 23rd, which was Monday, can be replayed. I know, and according to Bill, there were some volume issues. I hope they have to turn that up a bit when you listen to it. But Jim re-listened to the show. He will be coming back the closer we get to October. Beth Clay, I don't know if you remember Beth, but Beth Clay was the administrative assistant. I never got that right before. I got it right now. Was the administrative assistant to Dan Burton. And Jim had mentioned Dan Burton's name because certainly with that family plight back then, he ran into and came up against many government officials. Dan Burton was a friend of the family. Dan Burton was a champion for Thomas Navarro, and although Dan Burton is no longer the chairman of the committee that he headed back then, he's still on that same committee. And what it is hoped is that with the resurgence and the reintroduction of this topic under the guise of a documentary called Cut, Poison, Burn, what does that mean? What do you think it means? There may be an opportunity for the Thomas Navarro Patients' Rights Act to be reintroduced to Congress once again, and hopefully it will pass this time. Anyway, we'll keep you informed. If you want to be able to follow this a little closer and sort of a day-to-day, I've checked the website out a couple of times. I'll give you the website that you can go to. It's cancerbusters.us. Cancerbusters.us. And that is the site that the entire Navarro family has utilized for a number of years now, but it's getting a lot of play, a lot of hits, and you can follow just exactly what's happening through a number of different categories there in the opening page that you can click onto. Anyway, more on this subject as time passes by. Okay, our calendar is continuing to fill up. We'll have more to say on that on Friday. What we should do, because I always find when we're with them, we never have enough time, we are going to allow for that and cut to a commercial right now. Take a break and get with, yes, a good friend, an old friend to you too, Pittsburghers. You've known him for quite some time. What an extraordinary cardiologist he is. His information is something I really enjoy having the opportunity to call Jim whenever I have a query or a question. Many questions today, many queries today. You may have a few too. Be back in a moment with Dr. James Roberts.
This is Dennis J. Courtney, MD. You become confused about how best to manage your health. It's no wonder. It seems that every time you turn on the television or radio, another expert has yet another suggestion for you to follow that seems to be reasonable enough, but no matter how dutifully you follow the instructions, it just doesn't quite produce the results that you were looking for. If this confusion sounds familiar to you, give us a call at the Center for Complementary Health, where we'll make some sense of the confusion based on a blending of traditional and alternative medicine that we've been perfecting over the last 7 years. We offer metabolic nutrition testing, immune system repair, natural hormone replacement therapy, chelation therapy, cutting-edge allergy correction, and a host of other safe and effective alternative therapies.
Dennis J. Courtney, MD, is located at 3075 Washington Road in McMurray. Phone 724-942-3002.
All right, Jim.
Have you been to the doctor lately?
We're good. We're connected.
Top of your complaint list? Even if your doctor asks you what you eat, the recommended 5 servings of fruits and vegetables a day is a dream in your busy schedule. What if you learned of a product 5 years in the formulation that delivers 5 servings of fruits and minerals in just 1 ounce? That's right, it's through the Spirit. The blessings of the Spirit are now formulated into a delicious, whole fruit-flavored product rich in antioxidants and minerals. Your health is more than just a test result. It's a balance of physical, spiritual, and emotional factors. You work regularly to strengthen your faith, let through the Spirit help cover your nutritional needs in a convenient and cost-effective ounce a day. Call 1-800-442-3793 for a special promotional offer. Through the Spirit, a blessing for your good health. Through the Spirit, 5 servings of fruits and minerals with no added sugars. That's 1-800-442-3793 for your good health. Call them now, 1-800-442-3793.
Good morning, ladies and gentlemen. Welcome back once again to AM Impact on Your Health. Heard here in KHB 620 each and every Monday, Wednesday, and Friday from 8 to 9 o'clock. I'm Dr. Dennis Courtney with you on all those Mondays, Wednesdays, and Fridays. And today with you, too, is, I've mentioned it, an old friend. You know him well, Pittsburgh. You've come to really respect and trust his judgment and his advice. Of course, he was nice enough to put it in a tome that, sits on my desk looking at it right now, titled Reverse Heart Disease, now in collaboration with another pretty good cardiologist himself, Dr. Stephen Sinatra. Anyway, we utilize this textbook and all the teachings of James Roberts over and over again here in the office. Every once in a while, and I think if my recollection is correct, it's been at least 2 years since we had him back with us, and it was time to do it again. Let's say good morning and welcome him back. Good morning, Jimmy. Nice to have you aboard once again.
Delighted to be with you, Dennis.
Hey, Jim, am I right about that? It's been about 2 years since we had you on the show.
Is it? I guess it's been that long.
It really has, Jim, and boy, we can't let 2 years go by before we get you back again. Just as I thought about mentioning, we'll do this at least every 6 months, Jimmy.
I think that's a wise idea because so many new things are happening in medicine. It makes sense to share our knowledge.
Well, you always are the new age guy. If there's something new coming up, you've heard about it, read about it, and beyond that, you've done it. And we get all here in Pittsburgh get the benefit from the nice little relationship that you and I have developed over the years. Our patients here at my office enjoy the fact that they see that relationship. But I'm going to fire a couple of things that we've talked about before and because they keep coming up over and over again in my office. And then, of course, I'm going to open it up to you at some point about, here's the question, Jim. What is Jim Roberts doing now? Because every time I've ever asked that question before, boy, what followed blew me away. And I'm pretty sure it's probably going to happen again today. But let's go down memory road, cover a couple of topics that keep coming up over and over again, and maybe you can shed some light on them. All right, Jim?
Yes, fire away.
Well, first is this issue of AFib, atrial fibrillation. I can't tell you how many patients come to me with that problem. They are, of course, are put immediately on the protocol for the treatment of AFib, and it bothers them so much, and that is to be put on Coumadin, this warfarin drug, this rat poison drug, and they anguish and languish over this so much. Your book gave some hope to this problem by suggesting there were some other ways that you could actually treat this and not use Coumadin. Could you elaborate a bit on the issue of AFib, use of Coumadin, not using Coumadin, and what might be new? Is there anything new coming down the pike? Could you handle that question for me, Jim?
Yes, I can, Dennis. This is a difficult, vexing problem, and we do have a potentially new solution for it.
Oh, we do.
Yes, atrial fibrillation is a very common arrhythmia. It is age-related. It is wear and tear related. As a patient with heart disease ages, their risks of atrial fib rise. In seniors, 10% of seniors have atrial fib. And in atrial fib, blood flow is stagnant, clots form, it can break off and cause stroke. The risk of that happening is less than 1% a year in a 40-year-old, but it's 7 to 8% per year in an 80-year-old. Thus, the current dogma is for patients to go on Coumadin, a formal blood thinner, and stay on that the rest of their lives. And, of course, the problem is Coumadin has a number of side effects.
Oh, boy.
If you get the dose right, you have problem eating, and we're learning that Coumadin wastes not just vitamin K1, which is needed to make clotting factors, but vitamin K2. And K2's job is to work with vitamin C, calcium out of our arteries and out of our bones. When we put you on Coumadin, you're creating vitamin K deficiency. And this probably is our risk for arterial calcification, valve calcification, arthritis, and probably malignancy. And that individuals who take vitamin K have less malignancy. So we're using a drug to prevent clotting, which makes sense, but we're creating all these side effects of vitamin K deficiency. Thus, a dilemma.
So, what is the advice to those who languish over this? The protocol is pretty clear. Every cardiologist I know is putting their patients on Coumadin, as I believe they should. I mean, without any other alternative, certainly from their perspective, they're considering their patient safety as the number one. Are there other options? Your book, Reverse Heart Disease, now had a couple.
Yeah, first of all, we can individualize this. There are different grading systems to look at your risk. There's the CHAD-2 system. You get a point for age above 7, hypertension, diabetes. And we can better assess your risk. Some people would be fine with aspirin. Others need Coumadin. But what else can we do? The question is, will nattokinase, umbrokinase work as well with Coumadin? Now, I'm sure that your listeners are aware of nattokinase and umbrokinase. They are clot-dissolving agents. If you have a heart attack, we could give you intravenous or intracoronary clot busters, like it was first streptokinase and now TPA. These agents do the same thing, only they're oral. They're obviously not as powerful, but they do work. And we feel they do dissolve clots to prevent clots. It may be that nattokinase at 100 milligrams times a day will protect to the same degree as will Coumadin. But no one knows. No studies have been done. And they never will be because nattokinase is not patentable. So my take on this, if I think someone's at low risk of having clots, based on my assessment, I will put them on aspirin, nattokinase, and a lot of fish oil. And I think that will suffice. Conversely, if you're 80 years old, you have heart failure, and you're at very high risk of clotting, then Coumadin would be appropriate. So we can individualize this. And I think there is a role for nattokinase. Our dilemma is that it hasn't been proven. We don't know for sure.
All right, but there is something called you mentioned a CHAD system.
The CHAD system, yes. You get a point if you have it's a rating system looking at your risk for clotting and congestive heart failure, hypertension, age above 70, diabetes, or a prior stroke or a TIA. and we assign you a point for each of these. You get 2 points for a stroke or TIA. If your CHAD score is above 2, then Coumadin makes an awful lot of sense. If your CHAD score is only 1 or 0, then your risk of clotting is very, very low, and then aspirin would make sense.
All right, a new...
If you're going to be aspirin or Coumadin. Now, that's standard medicine. Those of us, you and I, and our colleagues who practice integrative medicine, we can also use fish oil. We can also use nattokinase to provide additional protection. So we can individualize it. The current dogma is we're going to treat everybody the same. That's what we're doing in medicine these days. That's dumb. We can individualize you based on your CHAD score and our assessment. And we can use nattokinase. So we can stratify you. And we have a new option, a wonderful new option that will be available in a couple of years.
What is that?
There is a drug called edoxaban. And we are involved in a clinical trial of edoxaban versus Coumadin in patients we're talking about with atrial fib. Now, Coumadin works by selectively depleting vitamin K or poisoning. It's a careful, controlled poisoning to make you K deficient enough that you don't make clotting factors adequately. But if we give you too much Coumadin, then you won't make any clotting factors to bleed to death. The problem is, if the amount of vitamins in your diet changes, and it may because you're going to eat different foods, that throws off the level of anticoagulation. So Coumadin is a terrible drug. Its mechanism of action is controlled poison, and so many foodstuffs and other drugs interfere with it. Edoxaban has nothing to do with vitamin K. It works on the final common pathway of clot formation. Specifically, it blocks factor 10A that converts prothrombin to thrombin. So that's a bunch of medical biochemistry, but basically it works on the final step. Everybody responds the same to edoxaban. It does not waste vitamin K. You don't have to worry about what you eat. One dose fits everybody. It begins to work in 2 hours and it's gone the next day. So this agent will be as effective as Coumadin, yet it's much easier to use, and we're not going to cause vitamin K deficiency. I think the vitamin K deficiency that we're causing is a huge problem, and our patients are going to pay the price for that. So we hope edoxaban becomes FDA approved. This process, of course, takes several years. We have 25 studies where they're getting either edoxaban or Coumadin, and they don't know and I don't know. We're both blinded to avoid bias. The patients are monitored closely, and this study is being carried out simultaneously in 5 continents. Kind of interesting. And the study will be done in a couple of years, and hopefully it'll show that edoxaban is safe and effective versus Coumadin. Then everybody who's on Coumadin, who is worried about this problem with vitamin K deficiency, will have another alternative. It'll be a drug, but it will be a better drug.
Loud and clear. I think one of the things that really bugged people about Coumadin is its implication. Well, not implication, it clearly is rat poisoning. And so to think, a patient thinking, I'm taking rat poisoning, there's a disconnect there. There's something that just does not resonate well. It might turn out that this new drug that's evidently, in listening to you, you're part of the trial, aren't you? You're using it.
Part of the trial. We've got people in the trial, and the trial's probably available in the Pittsburgh area. It's called Stage AF. And if you're going to be on a blood thinner, you might as well be in this trial because you have a 2 out of 3 chance of getting what I think is a better drug, and you get a lot of medical attention, and of course it's all free. Obviously, the blood work is free. There's a lot of information we're going to get in the study. We're going to be looking at your genetics to use. Maybe we can use genetic testing, looking for variants in enzyme function to predict who is the best candidate for a different approach. We're going to learn a great deal about the problem of atrial fib and how to make the right decision about anticoagulants. So it's kind of an exciting study to be involved in.
And will it still be measured by INR and prothrombin time?
It's a little different in that the INR is really an artifact. It's a laboratory device designed to measure proven effect. He would use some different parameters something called fibrin split clotting dimer, biochemical measures of clotting that are to monitor oxygen. So in the real world, if you have this drug out there, you won't even need to monitor it because you know what it is.
You won't have to monitor it.
You won't have to monitor it. You won't have to come in and get your blood drawn all the time because it is a predictable drug, and everybody pretty much responds the same, which is going to be very nice for us.
Would you still be at risk for bleeding if you had a traumatic event?
Yes, you would. You still have the downside of ER altering your physiology. That's a negative. But if, again, this is all a balance. It's all a risk-benefit. If you are taking edoxaban or you're taking warfarin, or for that matter, if you're taking Plavix after a stent and you are traumatized, say, during a motor vehicle accident, you're going to bleed much more than someone who's not on the drug. So it's a dilemma. And I guess the idea is we all ought to stay real healthy, not get sick, and you don't have to deal with it.
All right,
For people that have atrial fib, this is our dilemma. Can it be aspirin, that's nattokinase, fish oil? Should it be Coumadin or edoxaban? Those are the decisions that we as clinicians will be making with you.
All right. I expected you to be up at another level here. Lord knows you're in the trial, for God's sake. Thank you for bringing us literally up to date on this controversy. It plagues many a patient. The fact there's a CHAD score out there, I think, would be helpful to determine risk and maybe put somebody in the category where they can avoid both that drug as well as Coumadin. I will get that information about the CHAD score, which I heard for the first time here, as I usually have with you.
If you're not 70 years of age and you are only hypertensive or only diabetic and don't have the other factors, then your clotting risk is maybe 1% a year, and you don't need to go on Coumadin. And a lot of doctors, again, we sort of treat everybody the same. You have atrial fib, go on Coumadin. It doesn't have to be that way.
All right. Thank you. As I knew you would shed the light on it, it certainly is brilliant. And more on this subject as time passes on, especially because you're in the trial yourself. We're
very involved.
You're very involved. Okay, tick that one off. Let's move to something you elaborated on sort of as a side issue. I've come on the show a couple of times and I said, well, in the year 2010, the hot vitamin of 2010 had to be vitamin D. It was the biggie this year. Jim, would you agree?
I think so. Absolutely.
It really was in vogue. It had flash. It had panache. But as I said also, and you were the first one to bring vitamin K into this picture. You even have it in your book that's now been published many, many years. So, as would be expected, you were way ahead of your time. I say vitamin K is going to be the hot vitamin for 2011. Could you bring our listeners up to date a little more on this vitamin K issue? Because I believe they're going to be reading about it more and more, and they're going to become extremely interested in getting their vitamin K issues dealt with.
Absolutely. I think, almost all of our listeners, if they're not on supplements, are going to be low in vitamin E, vitamin A, magnesium, and iodine. This is just universal in the Midwest. But on to vitamin K2. K1 and K2. Vitamin K is a trace element. We use very small amounts in our diet. Very small because we can recycle it. We can recycle it unless we poison that enzyme with Coumadin. But we need vitamin K1 to activate clotting factors. And we need vitamin K1 to protect us from malignancy. Vitamin K1 has, vitamin K1 you get from green, spinach, broccoli. Vitamin K1 has a draining action on malignancy. Vitamin K2, its job is to prevent calcification where it's not supposed to be. It keeps calcium out of arteries, out of joints, out of cardiac valves, and in bone. K2 and D work hand in hand to manage calcium, put it in the right place, but it's going in the wrong place. Now, individuals who habitually take in a lot of vitamin B2 from their diet have less cardiovascular and less calcification of their coronary arteries. As it turns out, if you have calcium in your arteries, you make a protein. It is called matrix PLA protein. But if it is activated by vitamin K2, it will actively remove calcium from the artery. That's good. If it is not activated by K2, it will promote calcification. The more calcium you have in your artery, the more vitamin K2. The dosing hasn't worked out yet, but if we look at animal studies, older, sicker patients with a lot of active calcification probably 10 to 20 to 100 times more K2 than a young person. The more calcium you have in your artery, the more K2. K2 is very benign. A study was done in Japanese women where they took 38 milligrams a day. And the only thing that happened was their bones got stronger. We cannot overdose K2. So I'm thinking right now, everybody who has calcium in their arteries and valves should take a milligram, 1,000 micrograms of vitamin K2. And maybe more. We don't know yet. Now, for prevention, there was a study called the Rotterdam study. They looked at K in Rotterdam, the Netherlands. Individuals who took 40 micrograms a day from their diet had much less heart disease. Less.
That was micrograms.
Micrograms, I know. Micrograms, so there's 1,000 micrograms, milligrams. So just the diet, if you get 40 micrograms, you provide protection. And where do we get K2? From meat and cheese. This is another part of the French paradox. So I'm thinking that most of the nutritional supplements, modern nutritional supplements, contain about 100 micrograms of K2. Now, K1 is different. K1 and K2 are not interchangeable. So if your supplement just says vitamin K, it'll be something like phytoquinolone. That doesn't work for the arteries.
For the arteries.
K2. And so I think everybody ought to be on K2, and if you have heart disease, you ought to take more. Now, one caveat, if you are on Coumadin, cannot take vitamin K1 or K2. They will be destroyed by the yourself no good. But I'm thinking everybody ought to be on K2. A lot of research is done on what is the best dose. So far, one human study was about women entering menopause. Over those years, there's inflammation and arteries become stiffer. You can measure that. If you give women K2, that doesn't happen. There'll be many more studies coming out. I think we'll show the slow down the rate of coronary calcification. Now, the nanobacteria protocol that we were involved in.
Yes, that's how we first met.
Right. That included a lot of vitamin K2. And maybe one of the reasons that it worked, I think there were many reasons that it worked. One is that it had K2 in it. I believe that when all is said and done, it will be shown that vitamin K2 supplementation dramatically slows the rate of progression of coronary calcification. I think that the more calcium you have in your artery, the more rapidly the calcium score progresses, and that's because you have an incrementally increased individual for vitamin K2. That's what I think we'll find.
All right. K1 is for malignancies or preventing them. K2 is for heart disease and coronary artery disease. And you benefit from both, but you certainly, as a cardiologist, are coming down on the side of...
And it's good for bone. But there was a study in women with potential osteoporosis, and they gave them vitamin K1. And it had a little bit of effect on their bones, but it decreased their cancer risk. So that's a big, that's a real big. By the way, vitamin D dramatically decreases cancer risk. Study of women in Nebraska.
Oh, yeah.
They took calcium and vitamin, and it was a tiny little dose, like 1,000 units a day, and their cancer risk over 5 years, new cancer fell by 60%. So if everybody in the United States took vitamin D, I think our cancer rate is falling dramatically.
I think they're taking it, by the way.
I think so.
This year has been proven. Even our colleagues who aren't so much thinking about vitamins and minerals and the like, even your regular family doctor on the corner are getting very bold now. They're even saying things like 1,000 units a day. They almost stutter when they say it, but they're saying it, Jim.
I know. They're choking.
They're choking.
So, and we can't go wrong with vitamins as long as we're sensible. Now, I had a patient that was not sensible. A patient decided that he should take 100,000 vitamins a day.
Oh, boy.
Now, you can do that for a few days. As a matter of fact, if you have the flu, it'll help because it creates a natural antibiotic called capsaicin. This man decided to do it for several months. And he got sick. His calcium was high. He got dehydrated. And we stopped the vitamin D and we hydrated. He was okay. But so that's the only person who got sick with vitamin D. And he was just not taking, he just wasn't right.
All right. Well, I haven't come across that patient just yet. But for those of you out here who are thinking that way, cut that out. You don't want to go that high.
Absolutely.
All right. Number 3 on my list. You happen to mention it to me. I'm interested in your answer, and I don't know. We'll see if my listeners are too. One of the weight loss programs that had gained notoriety, I think Kevin Trudeau is the guy who resurrected this, was the use of HCG in a diet. This diet was originally developed by Dr. Simeons in Italy in the 1950s. HCG, human chorionic gonadotropin. And it usually scares the heck out of people with respect to thinking that you should take this natural hormone substance. It's only found really during pregnancy in females. Could you got to give things? You must have something to say about the HCG.
This is the most important breakthrough in medicine over the last 10 years.
Get out.
I have treated over the last 10 years about 600 people. The first 300 female patients lost an average of 22 pounds. The first 100 male patients lost 30 pounds. I've had 100 women do it twice, 2 rounds, and they lost, I believe, a total of 35 pounds. I've been able to dramatically cut back on the needs of my patients for diabetic medicine, for hypertension medicine, for their sleep apnea therapy. Really, adult onset diabetes is not a disease. It is a manifestation of overweight, visceral fat. And it's very difficult to lose weight because your body thinks you put this weight on intention to prepare for famine. We have to remember we're designed to be effective primitives. And primitives would overeat intentionally when they were worried about a famine. When we're overeating, our brain decides to give it intentionally. So our metabolic rate is adjusted to maintain our set point. Anyone who's really overweight tries to diet, they realize not much weight comes off because when you diet, your brain thinks you're starving to death. Because cave people didn't diet, they only starved to death. So when you're dieting, your metabolic rate falls dramatically, makes it very, very difficult to lose weight. So your Mother Nature's not going to give up any of this weight without a battle, except she would allow you to give up calories and energy to the baby you're carrying. Because survival of the species is more important than survival of the individual. Now, if a woman's pregnant, she may not always be able to find food because the hunters may come back late, or she might have morning sickness she can't eat. So we need a way of making sure a baby is fed, the mother is not. And the solution is for the placenta to make human chorionic gonadotropin. Its only job is to look after the abuse of the baby. It triggers the mother's hypothalamus, weight maintenance and control center, to tell all the fat cells in her body to release free fatty acids, triglycerides in the blood, so we have an auxiliary energy source to the baby the woman is carrying above and beyond her diet, which is why women don't gain body fat when they're carrying a baby. But after they deliver, they put on body fat when they lose the HCG. And again, that's part of the plan because in a world where the food supply is conserved, women with extra energy on board in terms of body fat will be better able to breastfeed their infant than a skinny mom if we run out of food again. So HCG's job is to mobilize fat from mother to child. this brilliant Dr. Simeon figured out that small doses of 125 units a day. Now, the placenta makes 1 million units a day when you're carrying a baby.
Oh, yeah, it's phenomenal.
Right. We're giving a tiny little dose, so we have a negligible effect on ovarian or testicular function, but the hypothalamus gets stirred. All the fat cells in your body are going to release energy into your blood. Your blood will be saturated with energy. You could follow a 500-calorie a day diet and lose a ton of weight. And because the hypothalamus thinks you're mobilizing this fat to meet the needs of the baby, your metabolic rate doesn't fall. So you can lose weight in allotment with a pseudo-pregnancy situation. And what we're learning is that, half of these adults who overweight, visceral fat, belly fat, is loaded with white cells releasing inflammatory mediators. Tumor necrosis factor, interleukin-6, etc. These are the inflammatory mediators that cause arterial disease. They cause dementia. They cause kidney. They cause high blood pressure. These inflammatory mediators are released from fat cells in the gut. They go to the liver and cause insulin sensitivity. Adult onset diabetes is simply an inflammatory disease. Inflammation is coming from white cells in belly fat. If we could help all of our patients with their belly fat, we could turn off their inflammation. Their adult onset diabetes will go away. Now, if you are overweight for a diabetic and I give you drugs to lower your blood sugar, that's well and good, but I'm not dealing with the real problem. And our drugs for diabetes typically make you gain weight. So we're lowering your blood sugar, and you're getting heavier and heavier, more inflamed. We really aren't getting the job done. But if we can help you lose weight, we can basically cure you of the diabetes and your high blood pressure and your cholesterol falls and your risk of cancer and heart disease and kidney disease falls. And this is what we need to do. Our population is getting heavier and heavier and heavier. 2/3 of us are overweight. 1/3 of us are diabetic. We're spending all this money, and people are experiencing so much misery based upon overweight, and the drugs and surgery aren't going to get the job done. We need to help lose weight, and this HCG methodology is a safe and effective, not very expensive approach. I have a DVD, it's a year old, on weight60ohio.com, which is a website that talks about this, and I encourage this. I think you have to do it with a doctor. It's critical that you do this with a doctor. Your body changes so rapidly. If you're taking a diuretic and blood pressure and sugar medicine, they have to be monitored very closely. We've had people take 80 units a day of insulin. They have to go off their insulin. So you have to, don't do this on your own. Do it with a doctor.
I certainly agree with that. And I guess the thing that I've heard from you, I'm picking out pieces because I've been practicing this diet a while. I'm happy to hear you have picked it up, and boy, have you ever, and that you find it to be a great compliment to your cardiac patients from a different perspective I hadn't even thought of. But the rub is that on a 500-calorie a day diet, which by all means, it's starvation. That's a starvation diet. That the HCG is protective, huh? You found it to be as protective as I did, and in terms of no harm comes to your patient because of 500 calories a day and being a starvation diet, that seems to be the biggest concern the patients have about going on the Simeon's approach to weight loss.
Well, it's not a starvation diet because if you can mobilize energy in your fat cells, that's kind of like you're getting an extra 1,000 calories a day from the body store. So your stomach may say, I'm starving, but your biochemistry doesn't think you're starving because you're accessing your own energy.
Uh-huh.
So that's how that works. I mean, if you could take some of your own fat, and that sounds terrible to consume it yourself, but you're accessing your own energy. And when the fat enters your blood, that is spent, and your appetite falls. So most people don't have a lot of hunger. Some people do. Everybody's different. Sometimes you give 700 calories. There's all kinds of things you can do to help people get through them. There are nutritional appetite suppressants. There are pharmacologic appetite suppressants. There are agents that will increase our metabolic rate slightly, such as certain peppers that increase metabolic rate. Green tea increases metabolic rate. So there's many things to do above and beyond just mitigation diet. But if you look at, I'm studying this to become board certified in bariatric medicine. I'm going to take the test next month.
Ah.
So I've been reading all the literature, and the drugs for weight loss, if you lose 10 pounds over a year, they think it's fantastic.
Oh, well, the HCG approach is so much more beneficial.
So much more effective.
Yeah, in terms of the amount of weight, it's just unbelievable. You cited some of what you saw in your own patient population, which is a pretty high number, it sounds. You say about 600 people you've treated. That's pretty doggone high. But, yeah, the amounts of weight that can be lost in this, I find no other comparison. And so for listeners out there, glad to hear you're on it. You do have a quick call, and you don't mind taking a caller, do you? Hey, come on ahead. You're with Dr. James Roberts. Go right ahead with your question.
Hi. My question is about the HCG.
Okay.
I understand what you were saying about not taking it, unassisted, because of various health problems. What about someone who doesn't have those issues? And what about the homeopathic version? What do you think about that way of using the HCG?
All right, Jim.
Yes, if you are young and healthy, and you're not on any medication, then this can be done fairly safely. I still think it makes sense to be evaluated by a doctor to make sure you don't have some unknown conditions like kidney disease or liver disease, something like that. But a patient who doesn't have a lot of other health conditions, it's pretty straightforward and easy. The only thing that can go wrong is hunger. And having said that, 1 in 250 of our patients will have a gallbladder problem. With any methodology, you can wait quickly. If you have gallstones, they can activate. Men can get gout. But in otherwise healthy people, this is unlikely. Now, the homeopathic, no one knows if it works or not. People are selling it over the internet, and I don't know whether it works or not. There's been no study of it, and we just don't know. I would encourage people to use pharmaceutical HCG, either bought in a pharmacy or made up by a compounding pharmacist working with the doctor. The homeopathic may work, but no one knows. I think that a lot of people are taking advantage of this level of interest, and they're probably selling a lot of junk. So that's all I could really say about the homeopathic. It may or may not work, I don't know, but I'd be very careful who you're working with, make sure you're getting good stuff.
Fair enough. Thank you for your question. Thank you for your...
I have another part to the question. What about the average person who doesn't have a lot of obvious fat or belly fat? Is it at some point advisable for that person to do HCG to get rid of kind of that hidden visceral fat that may cause problems?
Yes and no. We want to be trim. I mean, the average American is overweight, and we call that normal. We all really want to be ideal. We want to be fairly lean and athletic. We don't want to be scrawny, but we want to be trimmer than the average American. Now, it gets a bit complicated in that overweight per se is not it's visceral fat. Women that have subcutaneous fat on their thighs or their derriere, that fat is benign. That fat is not inflammatory, and it really won't hurt you. That might be a cosmetic issue for some, but the female distribution of fat is really benign. It actually serves as a depot for excess lipids. The belly fat, the beer belly fat that you see in men, that is the dangerous fat. Fat that you can't pinch, that's in between the organs and the belly, that's what we worry about. So a better measure would be the waist circumference. And there are various measurement schemes about what is the too large waist circumference. That's what we're interested in. So we're interested in getting rid of belly fat. We want you to have no excess belly fat. The HCG works well for belly fat, for visceral fat. If a younger woman just doesn't like the way her thighs look with subcutaneous fat, the HCG doesn't work that well because that is not a threatening fat. It's only good for the threatening fat in our belly.
Okay, ma'am. Thank you.
Thank you.
Okay. Enough said on the subject. We move on. Jimmy, are you ready for another topic?
I am.
One that I know you have quite a bit to say on because you've been utilizing this process of ECP in your office for many, many moons. We've had patients go back and forth. Some people, you got many a patient who visit you from Pittsburgh to be evaluated by you, and then because of geographics, they come back and do ECP with your approval at our office. Angina, and now a new second approved use of ECP is for heart failure. Am I right about those two approved?
It's not covered by insurance for heart failure.
Oh, just angina for the moment.
Right, but it works. It's reasonable. It's okay to use it. There's nothing wrong with it. But for angina, particularly in individuals who are not good candidates for standard revascularization, it works beautifully. We've been using it for 15 years. And the beauty of it is it can't hurt you. The worst thing that can happen is you don't get better. And when we do bypass surgery and stents, the worst thing that can happen is that you die.
Yeah. But,
so it is
well, you get away with words.
Essentially risk-free approach to the problem of chronic disease that helps just about everybody. Not only are we generating natural bypass collaterals, it has an effect with passive exercise, so the biochemistry of every blood vessel in the body improves to become a nitric oxide vessel. So it has a therapeutic value, and in a sense, it has a preventative value as well. And it's just a wonderful therapy to have. It's not talked about because in medicine, the fees for revascularization are so great that is just kind of put on the back burner, except by you and I and others like us think it's fantastic. It will help in heart failure. The study that was done, they kind of set the bar too high. And while they showed it was helpful, they didn't meet their a priori goal. So Medicare will not cover it in heart failure. Hopefully other studies will be done, and it will be covered in heart failure. But it does have some value in heart failure, but its real magic is coronary artery disease.
Now, I know it's real magic. In fact, you are just like me. I've come to be very greedy about this. If somebody comes in with angina, I say, you know what? Get on that machine until your angina is gone. And pretty much, I can expect it to happen. I know you've seen that too. But something that I keep seeing happen over and over again, and I guess you had to see the same thing, is three different other areas that never get mentioned. One, peripheral neuropathy. Two, kidney disease, where an increasing creatinine level gets to normalize by virtue of doing ECP. And number three, and it's been a mystical, magical observation, memory loss issues are getting extremely assisted and helped by ECP. Have you had, can you comment on any of those additional three things that you find have occurred?
Yeah, we have to remember we're improving blood flow not just to the heart, but to every organ in the body. And you can look at hearing, you can look at blood flow to the retina, you can look at blood flow to the kidney and urine output. They all improve. ECP also has an antioxidant effect. So it's like passive exercise. So every organ system has something to gain. And if blood flow to the kidney improves, the creatinine may improve. If blood flow to the brain is lazy and you improve it, the brain's going to function better. In China, they will use ECP to treat acute stroke. They will also fit cuffs over the arm, and they will use it to treat stroke to collateralize stroke. So there's been an erectile function. Erectile dysfunction often exists.
Oh, yeah, good point.
You're making nitric oxide, and you're increasing blood flow to the pelvic organ.
That's another good point forgot to mention. Thanks for mentioning it. So ECP is a winner all the way around. Look, I'm really feeling bad here because I'm so interested in asking you specific questions. We never got to one of your new things. I don't know what a quantum well is, but I'm going to say to you, could you tell us in brevity what it is? And can we come back and revisit you not too far in the distant future to talk about quantum wells once you...
Right.
Okay?
The website is firstlinewellness.com.
Firstlinewellness.com.
And they will tell you part of the story. It's too fantastic a story to really put on the web. But it, and I can't prove any of this, but I think it works, and I think it's the most wonderful breakthrough in medical science that we're going to experience in our lifetime. This is sort of a fusion of clinical medicine, quantum physics, and our belief system. The quantum physicists tell us that there are waves of energy that inhabit the space, nucleus, and the innermost ring of electrons in all of our atoms. And that these waves of energy move in and out of it. It's the glue that keeps us together and keeps us connected. And that these waves of energy have knowledge and extreme power. And that this energy is responsible for placebo effect. We get better when we breathe, we get better. We doctors help our patients, but typically the patients are really kind of getting better on their own. We all understand the placebo effect. The theory is that this energy, waves of energy, that have infinite length and infinite vibrational velocity, were created by the creator of the universe as a means of helping humans establish their health. And this is the placebo effect. And it's talked about in great books of every great religion. And so maybe everything we learned in Sunday school growing up is true. And that there is a creator of physics, creator of the universe.
Only coming from you, Jimmy. I can see that you've got a lot to give on this, and it's just unfair to try to have you give any more. We're at the bongo point of the show. It's time to get on out of here. Promise to come back, Jimmy, soon.
I will. FirstLineWellness.com is worth looking at.
I'm going to go there. I'll be talking to Shelley. Until then, this is Dr. Dennis Courtney with Dr. James Roberts saying so long for AM Impact on Your Health.
Thank you.
For more information or to make an appointment, call 724-940